I'm Christina, and I'll be your host for Pain in the Trenches, where evidence meets the realities of clinical practice. Because for most of us, that's exactly where we are. We're in the day-to-day realities of clinical practice, working with patients who are often complex, frustrated, or just not getting better in the way we'd expect. But also, if I'm being honest, there is still a gap between what we know and what actually happens in the clinic. So that's really what these conversations will be about, where pain science is right now and what it looks like to actually apply this in the clinic with our patients. So with that, I'm really excited to bring in Belinda. Belinda has a ton of experience when it comes to pain neuroscience, education, and actually applying this in practice. She's been in this space for over 30 years, working with complex, persistent pain, running her own outpatient orthopedic clinic, where she has found herself focusing on those tough cases that don't always fit the traditional model. She originally trained in South Africa, where she brings a strong background in manual therapy and pain science, as she is a Maitland certified orthopedic manual therapist and a 2023 fellow in pain science. She's also a dedicated APTA clinical instructor and was just at CSM this year presenting. So she is very much in the middle of these conversations as they're evolving. So Belinda, I want to start here. Good morning. Can you tell us how you got into this, and from your perspective, why is this conversation important right now?
So for me, I really wanted this webinar to be a space where we could discuss pain science and how it's being used in clinical practice. Part of it is, I think, there's so much information out there on the internet, and to know what is valid and solid information and how it's being applied is often difficult. I've always been driven to learn, and honestly, after 30 years, I still enjoy what I do and I want to keep enjoying it, but that does mean constantly learning. And I was lucky enough to meet someone like Adrian Lowe about 20 years ago, 20 plus probably. And he introduced me to a lot of these concepts. I'd followed David Butler and Laura Mosley's work as well. And, people like Steve Schmidt, who teaches with evidence in motion, they have shown us that there's a lot more research that needs to be done and that is ongoing. And I did get into this mainly because I was like a lot of physical therapists with patients who weren't responding the way I wanted them to. There was no fix. There was no one thing that seemed to make it better. And pain science started answering those questions for me. So the other thing that I've seen evolve in the last few years is how do we actually apply pain science in the clinical application? So it's all very well having all the science and the hard evidence, but how do we actually use it day to day as physical therapists? So I thought this webinar would be a really good way to bridge the gap between the information out there and how we can actually use it with patients. And part of the sort of drive in me as well is, having now been in practice for myself for 20 years, I've watched so many young physical therapists burn out. And I honestly do think by understanding what your patients are going through, you're more compassionate. Let's put it that way. You're more compassionate with your patients. And I think because of that, you have less frustration as a clinician, because let's be honest, we all want to help. We get into this profession because we want to help. And if we understand what they're going through, we can step back and maybe understand the emotions and the frustration that the patients are going through, and also then understand those very unusual presentations and why they haven't improved. So I do think pain science bridges that for us, but I do think that it would be good to have conversations with experts that are using it day to day. So I think that's where I do think this presents a whole different platform for us to talk about. And I know that in the coming months, we're going to be interviewing very different specialists. So I'm hoping that will help us kind of cross that bridge, if you will. Now,
I think a lot of us can relate to it.
Exactly. And so on that note, Christina, you are the person I thought of bringing into this because I think that you've seen both sides of it. And so when as let's have you go back a little bit for me. And when you think back to being a patient or even being a clinician, let's go back to when you were a clinician. What was the shift for you as a clinician to becoming the patient?
Yeah, so I was a physical therapist, and then for so long, I became that patient that the kind of patient I didn't know how to treat. I believed, like a lot of us are trained to, that if you find the problem, you can fix it. But then I found myself on the other side where going through 5 neurosurgeries, dealing with persistent pain, sitting in appointment after appointment, just like hoping someone could explain to me what was going on. And the hardest part wasn't just the pain. I was starting to lose hope that anything would help. So what I didn't realize at the time wasn't that the problem was that no one cared or no one was trying. It was just I was missing part of that picture that you're talking about.
And when you were going through all of this, how were you making sense of your pain at the time?
The way I understood pain at the time was through a very biomechanical lens. I was trained to look for a structure. So disc, nerve, joint, something you can point to and say, like, that's it. And if you couldn't find it, you can fix it. And to be clear, there's value in that. That is what we do as physical therapists. But what I didn't realize at the time was how much I was relying on just that as an explanation for my pain. Because at that point, when I became the patient, that model just started falling apart. Or not necessarily like falling apart, but it didn't account for everything. Because I had the imaging, the diagnoses, the surgeries. But it was still, things were so frustrating. And instead of just falling into place, I was still in so much pain.
And when things were still not improving, how did that influence your way of thinking of the situation?
That's when I really found myself in the trenches. And no one was doing anything wrong. And that's what made it even harder. I had a good medical team. I had people who cared, people who were trying. And that's when I found myself deep in it without a path forward. But despite all that, I just wasn't getting better. I started to feel like I didn't quite fit in anywhere. Like I was too complex, or I just wasn't getting better in the way I was supposed to. And over time, that really starts to get to you, because when you don't have an explanation for your pain, your mind starts to create one. So
yeah, exactly.
Did something go wrong?
What would you say? What was the turning point? What after all of this was unraveling? What helped you change direction?
Well, then I, by chance, stumbled upon you, Belinda. And to be honest, I didn't go into that physical therapy appointment thinking like this was going to be super helpful or this was going to be the thing that changes everything. I had already seen a lot of providers at that point. I felt like I had tried everything. So there was a part of me that was still like somewhat hopeful. But it's also very guarded. At that appointment, you let me tell me your story. I mean, you let me tell you my story, and you listened. But at the same time, you weren't looking at me like you're like, I have no idea what you're talking about. You're way too complex. Like, I don't know what to do with you. And that was new for me. So you opened the door to a completely different conversation. Instead of just asking like, okay, like what structure is this? You started asking like, well, how is your nervous system responding? Like, what has your system been through? And then it didn't happen overnight. But I remember thinking like, could she be onto something? Or like, maybe I found the missing piece. Not because you were necessarily like treating me any like differently per se. It was just, you were sprinkling in the pain neuroscience education into like each one of our sessions. And the two of those together is what helped me like move forward in my recovery in ways like I was worried I never would.
Well, and it's very hard because we are shifting a whole way of thinking. So that's a big adjustment. So what would you say after, like, as you started to shift how you approached this or how you thought about pain, how do you feel that changed your approach to yourself?
Yeah, once we started looking at that full picture, so like the biomechanics and the pain science, that's when things began to change. Like, so definitely not overnight and not in a straight line, but gradually I was able to see my pain differently. For so long, every time I felt pain in my mind, I would immediately jump to something must be wrong. I still have fear, but Belinda taught me, gave me the tools using the pain neuroscience education. Yeah. I can talk my way through it, not immediately jump to biomechanical explanations, but rather like find ways to support my nervous system.
And if you zoom out, what do you, like, from your whole experience, like from meeting me to where we are now, what would you say is most important for people to understand about pain or pain science now?
Yeah, so I think now would be a good time to like take a second and speak to the two groups of people who might be listening to this, because I've been on both sides. So first, if you're a patient and you feel like no one fully understands your pain and you've been searching for answers and not getting them, or like your symptoms just aren't making sense, I want you to hear this. You're not broken and you're not alone. Even if your pain hasn't been clearly explained yet, that doesn't mean it's not real. And it doesn't mean there isn't a path forward.
Absolutely.
If you're a clinician listening to this and you've ever had a patient like me, where things just don't quite add up, or they're not progressing in the way you'd expect, or you just like leave session thinking like, I don't know what else to do. You're not failing them. You might just be like missing part of the picture the same way I was. And the good news is once you start to see that piece, it really changes everything. And, not for only your patients, but just for how you practice.
Yeah, absolutely. Yeah. And I think for a lot of clinicians, this is what they struggle with. So I'm hoping that we can help them bridge this gap a little bit by having these conversations.
Yeah. That's really why this matters so much to me, because I feel like I know what it feels like to like be in pain, not have the answers. But I also know what it feels like to be the clinician who just genuinely wants to help, but doesn't feel like they have like the full toolkit.
Absolutely.
I'm still in the trenches and recovering and learning, but I'm not stuck there anymore. And that's like the big difference, because there's this whole world of clinicians, researchers, and educators out there who are expanding how we understand pain, and actually helping patients like me move forward. And that's what this series really is all about, is bringing those voices into the conversation, bridging the gap between what we know, what we do, and just making sure those patients don't fall through the cracks the way so many of us have. Because the webinar series, Pain in the Trenches, isn't about being stuck. It's about what happens in the hardest parts of recovery and how we find a way forward. So I'm really glad you're here for it. And honestly, that's why I'm really excited to have this conversation with you, Belinda. To start off, I would love to ask you, what do you wish every clinician understood about pain before entering practice?
I think for me, one of the biggest things, and the reason I wanted this webinar to be something that would be available to people, is for clinicians and practitioners, and I'm talking across the board, medical practitioners, everybody, for them to understand that pain neuroscience or pain science is not a separate entity all of its own. It's something that we have to have as a skill to be an effective practitioner. And it's been studied a lot, agreeably, in chronic pain, but that's getting a lot of coverage because of how much chronic pain we deal with. I think last year it was the US Pain Foundation that said it costs the US close to $635 billion to manage chronic pain in the medical field. And so it's a huge number that we're dealing with. But we also have to realize that it's the science of the body. So we have to translate it for patients to understand it in every avenue. It's not just going to be in chronic pain. And it also means that all medical practitioners should have an understanding of it. So even, for example, I think a lot of the time people don't think of it in acute pain. But imagine if we were able to get hold of that patient who fractured their arm right before they go into surgery. If we have that opportunity, we would be able to explain to them, this is what's coming. They're going to stabilize the bone. The first 3 days when we're in a pro-inflammatory phase, it's going to get very angry and swollen, and you're going to be in more pain. But then as it switches over, it's going to recover. You're going to ice it. You're going to rest it. And then by the third week, you'll be moving. And the whole way through, you're going to be moving your fingers, and you're going to still be using some function out of the elbow. So if we just took something like that, and we were able to step in and educate the patient before they went through everything, we'd be reducing their fear response, and we would be able to get at it before it even starts. And still now, the biggest predictor of chronic pain or something like CRPS is the intensity of the acute pain 5 days after an intervention or an injury. So ultimately, I think what I would want clinicians to realize is that it applies to everything. It applies to sports. It applies to rheumatology. This is just the physiology of our pain mechanism. And ultimately, we would like practitioners all to have an understanding of it and not just sort of kind of put it into the box of this is complex pain's problem, and that's why we have pain science specialists. So I really want to find a way to make sure that we bridge that. And I think with the speakers that are coming in the next few months, you're going to see that it's used in every avenue, not just in chronic pain itself. Because in my community, I started becoming known as the chronic pain specialist. And don't get me wrong, I love the fact that word of mouth has kept me busy, but I also want to make sure that people understand, or clinicians understand, that it's for everybody to understand. It's the verbiage we use. I think there was a physical therapist who said it should be the air that we breathe. It should just be how we actually address someone's body. It's a whole body that we're dealing with.
Yeah. I love that you pointed out that this isn't just something that we can use when things get complicated.
Yes.
It's something that we could be using in just the very first interaction with it.
Absolutely. Yeah. I mean, I had a sprained ankle patient last week who she came in with such extreme pain, excruciating and shooting up her leg, but all the imaging had been done. And we knew, I know her orthopedic doctor, I know he's good at what he does. It was a grade 2 sprain. Everything was stable, but she had shooting pain up to her hip. And just by being able to explain what her nervous system was doing, we were able to get her to veer away from going into a severe pain state and understand what was happening and go into a normal recovery pattern. So I definitely think more clinicians need to understand this is applicable in every avenue.
Yeah, definitely.
Yeah.
So if a busy clinician wants to start incorporating the pain neuroscience education into their practice, what's one thing they could start doing with their patients tomorrow?
I always come at it of sprinkling it in. And what I mean by that, you mentioned it, and it's the concept of using it in every session with the patient. You might have to front load that by giving them one in-depth session. And again, because you've been my patient, you know that we sometimes have to do a separate session and hopefully give them a foundation to work with. But if you sprinkle it in while you're doing your exercises or while you're actually, working on their back, that's giving them a little bit of bite-sized information, if you will. But the other thing I would say is, every single patient I work with, I go into an explanation of the nervous system, and I bring out a laminated picture I have of Harriet, according to the history, the first dissected nervous system from the 1800s. And I show them the continuity of the nervous system. I make them understand this is a very real structure. This is something that is not just this imaginary, invisible thing inside us. It's a solid structure. Yes, it has delicate parts to it, but it's also very tough. And if a patient sees it and they understand that this is just part of their body, and I think there's less fear involved in it, because they don't then seem so entrenched in just because there's pain, there's a structure like a ligament or a joint or a muscle that's causing the problem. So I think I do lean on Harriet a lot because it's quick and easy. And a young clinician, you've learned all about Harriet. You've learned about this nervous system. I just maybe think you haven't been given the tool to say, this is how I actually teach the patient about it.
Yeah. And I've seen Harriet many times. I can attest to that. But yeah,
absolutely.
how simple this is. You can just sprinkle it in. You don't, because I think a lot of clinicians think like it has to be some sort of big structured conversation.
Exactly.
And that can feel overwhelming.
Yes. And I think that's the thing, is that it's a skill you learn, but I think to not be so fearful of it as being a tool that can help your patients get better.
Yeah. So what mistakes do therapists commonly make when trying to explain pain to their patients?
So I'm very lucky because I work with a group of physical therapists who are very eager to learn, and they've all, as they've come on board with me, I've educated them and they've run with it as well. So they're very eager. But because I've had so much more training, having gone through the TPS and then the Pain Science Fellowship, I think it's good for me to watch how they work, and then together we can work out some of their mistakes and some of, honestly, my mistakes. And I would say one of the bigger ones is not getting too technical and too scientific. Because firstly, when someone's in pain, we talk about almost like the frontal lobe is a little hijacked, because now your reasoning is under, if you will, attack. You can't think straight. Because if I ask you, when you think about that first time I sat down and gave you a full explanation, how much do you feel like you took in?
Yeah, it was compared to when I first started to now, I can take in so much more. And
that's also, yes, and that's why we have like a family member sitting in often, so that they can be hearing it as well. But we all have to develop, as they say, this big iceberg of knowledge, but the patients only need to know the tip. So I would say be careful of being too scientific. I found, though, when I'd gone through TPS and had been a big break till I went through the fellowship, I had almost become so, if you will, unscientific, because I was explaining it to patients in a very straightforward, basic way, that when I was then exposed to other professionals, I was actually almost nervous that I wouldn't know how to talk in scientific terms again. Okay. So we must realize that patients don't have our knowledge. They want to just understand what's happening with their body. And when I first started training, and people like Adrian were teaching, and all of us were just learning this, we used what we call the fire hydrant approach, which is just open the floodgates and teach them everything in one session. And many a time that is just, firstly, too much, but secondly, to actually take in that kind of scientific information when you have no science base is just sometimes too difficult. So I would say, if you are new to this concept as a practitioner, take it in small bite sizes. As I said earlier, sprinkle it in so that it's easy for you to explain. Maybe find things that you see as yours, nice, easy metaphors that you can explain things. And take things that are from the patient's perspective. Like, find episodes that have happened with them so that they can also apply it to their own bodies. But just make it bite-sized, make it easy. We refer to it as almost like you eat an elephant one bite at a time. I don't even know who said that, but it's one of those things that it's small bite sizes makes it easier for everybody.
That's so true. Because when I was a patient, it was always just like, if you gave me like the one or two things just to hold on to, I didn't have, was so helpful compared to knowing the entire
The whole
reasoning,
story.
the whole
Exactly.
story. Yeah.
Yeah.
What changes do you see in patients when they truly understand their pain?
So I think this is where the biggest shift will happen, because that's where, when we talk about stages of recovery, you'll see someone, the readiness for change shifts completely, because now they actually become engaged in their own recovery. There's the fear of movement starts becoming reduced. And for some, it will take a long time. Like you even said, it's you're hearing it again and again and again. But once they understand what's happening, they're more willing to kind of, we refer to it as touch it, nudge it, push through a little bit, but not like force into it. And once they understand their pain and they truly get that understanding, then they're like, okay, now I can push that boundary. Now I can almost like understand that I'm going to have some pain, but I'm still going to get more function. And that's where we start getting them to see that their movement is becoming their medicine, and you will see that crossover for them. Yeah. I also would say, though, is that I have seen that I've had to be very honest with patients about this, because you can never promise someone, if we take the big one, CRPS, you can never just say to them, you're going to be at 0% pain.
Right.
You have to come in and say, small things are going to change you. Sometimes it's just giving them that little bit of hope of, let's take this in a stepwise fashion. And even from your perspective, when we talked about a walking program, you have to start slowly, because then you trust your body.
Yeah, that shift that you're describing is so powerful. And that piece about hope is huge, because for a long time, like these patients, that's like the piece that's been missing. So just giving them some of that is huge.
Absolutely. Yeah.
So how does the overuse of biomechanical explanations affect patient outcome?
So this is a tough one nowadays, because we are in a situation where, and especially here in the US, we are a very privileged society where we can get imaging very easily. And coming from another country where it just is not something that we have access to, patients get it explained in words that are fear-inducing and scary. And I think we don't realize how powerful the words are that they read, because then they put them into Google or now ChatGPT, and they start hearing what it means. And by the time we see them, they have already had this whole concept built up in their heads. And when you sort of think about the image of that we can see online, you start realizing that they now get this very structured, damaged, degenerative, horrible situation in their head. And so sometimes I think this is where we have to really step in and re-educate patients, but we have to de-educate them first. So we often have to go back to, these are the studies. Out of a group of pain-free patients who have their necks imaged, you're going to see that 90% of them have some kind of disc bulging, but they don't have pain. Or my favorite one, because my daughter's a hockey fan and we're in the middle of Ducks playoffs, so everyone's following it here, is that you can take a group of professional hockey players who have got no hip pain, and 66% of them will have degeneration in those hips, and severe, significant. Yeah. So we often have to really step back and realize, with all of the imaging that's out there, we have to educate patients what it means. And then also to realize that it can't be our enemy, but we have to make sure that it's not overfeeding into this negative sort of biomechanical image that patients have of their bodies.
Right. And trying to do it in a way where we're not like dismissing them.
Exactly. And even the fact that patients now have access to it way before we sometimes even see them, or before their doctor even sees it. So then by the time they see the doctor, they are in a panic, because they've now heard that there's foraminal stenosis. I mean, that's scary. They don't know what that means. And when they go online, it says, well, it's the space around your nerve that's being compressed. And that's panicky for anybody. So I
Hmm.
definitely think we're just in a bit of we are in a challenging world. And so for clinicians, I think you just have to lean into the pain science and really make sure they understand this is a scientific thing we're explaining, not just some sort of delicate system that's in your body.
That's true. That's a really good way to put it.
Yeah.
um, so, is there a patient story that really changed the way you think about explaining pain?
So I think for me, probably one of the stories that always jumps to mind is a patient who I was able to flip it into success. So I will say we were able to turn it around. But the reason I always remember her is she was a very, if you will, simple case. She should have been very straightforward. She was this very sweet patient who came in with very simple sort of, neck pain, nothing too unusual.
Hmm.
And it was severe enough that it was affecting her sleep. And her husband was a patient and he got her to come in and see me. And I did my sort of typical orthopedic assessment, checked her range, muscle strength, all the good stuff we're meant to do to check on a patient, a good, strong physical assessment. And honestly found some loss in movement. So decided, okay, this is what I'm going to do. I'm going to treat with my very manual techniques. So I'm going to mobilize her neck. I'm going to get some blood flow, get her face down on the table, do all the good things. And she sat up and she felt better and she was like, great. And objectively, her range had improved. And I was very trained not to be greedy for gain. So it was like, okay,
Yeah.
great. We did so well with that one. Sent her home with some, use a bit of heat and let's see how you are in 2 days. And she came back in and the woman that I met was completely different. She was angry. She
Uh,
was, I don't even know how to explain it. She went from just being so sweet to just being this very almost verbally aggressive in your face person. And I felt terrible. I was grateful she came back. And I
yeah.
was grateful that honestly her husband was a patient who'd had results because he was the one who said to her, just go back in. I'd had a little bit of heads up because I'd seen him in between and I knew that she'd had a bad response and a rebound response, if you will. And so I sat her down and explained her nervous system. I was very early on in my P&E exposure at this point, so understanding pain
Yeah.
science was not easy. And I had fallen back on my sort of standard manual work. But once I explained to her that, your nerves have got a little bit more movement around them now, there's more blood flow. I often use the analogy that suddenly they had to run a marathon and they're not used to doing that. And she sort of sat back and she said to me, well, why didn't you tell me that before? And it was one of those things. She let me treat her again. I definitely went more into explaining to her even after I treated. And
Yeah.
I think for me, the biggest, like, if you will, learning tool was that I had to understand that education had to come in with this. It has to come in with every patient. And don't get me wrong, we all know that there are those of us that are in the manual therapy world know it works. We all lean on it. We know it's something that helps. But we have to realize that in some of these cases, their pain mechanism may be a little bit more intense, if you will, than we had maybe wanted it to be.
Yeah.
And so ultimately, I always come back to I have to always step back now and say, does this fit the picture? There's so much more research that helps us decide that now, that I think
Yeah.
now that we can put people into their, if you will, categories of either nociceptive or nociplastic pain or neurogenic pain, it gives us a framework to work with. But I will never forget her because being a simple case, if you will, a simple patient in
Yeah.
neck pain doesn't mean that I can not bring in pain science. I always have to.
Yeah, I think I mean, a lot of people will relate to that. And that's such a good example about how, like, you don't wait to bring in the pain science before things get complicated.
Exactly. Yeah. Because I
Um,
do think sometimes we think that. I think we sometimes think, and I'm going off on a tangent here, but I think we sometimes think that, again, I think that's why I went to this webinar. Let me get my thoughts ready. Is that
yeah.
I want people to understand it's not just in the CRPS cases, which I think is often what people think.
Right.
I think they often think it's only in chronic pain that we need to stop and do education. I think we have to understand it comes into everything.
Mm-hmm.
But I also think, kind of, again, going off on a tangent, is it's a skill. When we are learning to strengthen a patient, when we're learning to, like, if you flash back to when you were in school learning all of this, you practice things. You were shown a technique and you practice it. You practice it on your family. You practice it on your friends. Your teachers are always telling you, do this on different bodies. See how different people respond. And pain science is no different. I realized recently I had never sat down and gone through a pain science education session with my husband. Now, he's gone on this journey with me. So he's gone on this journey with me because when you're married to a PT who keeps studying, you kind of have to just make space in your marriage for that. But he's also gone through his own injuries. And I never realized I hadn't explained it to him. And afterwards, he said to me that it was like mind-blowing for him, that this was how his body was working. And I know I've given him bits and pieces along the way, and I know I've used him to practice certain things on when it comes to pain science, but I'd never actually stopped and given him a full explanation. And so I really think part of this webinar and part of this discussion is that I really want people to understand it is a skill. You asked me about clinicians' errors earlier. One of the errors that we see is patients walking away thinking that it's all in their mind. And that can be very hard to avoid. Last week, one of my staff members came this close to a patient not coming back again because we were trying to bridge the gap between her stress response and her spike in pain. Yeah. And it was maybe not explained, or we picked the wrong moment to explain it to the patient. And so for clinicians out there learning to use this, it does take skill. It does take time. You are going to have failures, but practice it. Practice it on the really tough family members who don't even know that we know what we're talking about. Find someone who's going to be a challenge.
I can think of some. I'm just kidding. Sorry, family members.
But that is the thing, is that like we have our family members. I mean, I'm from a big family of 5 and I'm the last of 5, and guaranteed my older brother, who's a medical specialist, may not realize what I know. And that's okay. Yeah. And he might someday need me to explain it to him, and he will be the challenge, and that's great. But practice on your friends who are maybe PTs or occupational therapists who just have never been exposed to this, or are potentially only in what they think is the sports world and don't think they need to understand this, because then your skill level is going to jump. And it does. It's like any skill that we have. It takes a long time to get there. And so for me, it's the air that I breathe at this point. It's the lens that I see everything through.
And it's taken a long time for you to help me with that, but I can see how powerful that is, because now, I mean, I still have pain, but now the difference is I'll have pain and I can kind of talk myself through it and be like, okay, like, it's my nervous system just like maybe fatigued, versus it used to be like, oh no, something's wrong, I need another surgery. And that is just such a powerful tool to have.
Well, and I think once I had a patient trying to explain it to him, and he pretty much kind of halfway through said to me, well, that's your paradigm. And I can, because I've been doing this a while, I can be fairly firm with a patient when I know them as well. And I had to say to him, this is not a paradigm, this is the science. And with him, I went very scientific, and I used a lot of research from people like Eunice and other people out there who've shown us how our chemistry from the periphery actually crosses the blood-brain barrier, and it will affect our thinking, and it will affect that chemistry of our brain. And so I think sometimes you do have to go very scientific, but it does take a long time, because it's not an easy thing. And honestly, that's, I think, why we see so much burnout, is because if you think about it day in and day out, if you're not able to help people, then you're going to feel like you're failing at your job. And again, all of us went into this because we want to help. And you must have seen it even in colleagues who you might have had work on you when this all started.
Definitely. Yeah.
Yeah.
Yeah. I think a lot of us can relate to that. Because you feel like, I mean, we all went into this profession wanting to help our patients.
Exactly.
And so if you end up going to work not being able to help anyone, then, well, yeah, burnout could get
It's a big deal. I mean, recently I interviewed a young PT who had just graduated and had taken a year off to go and connect with family in Korea. And he came back, and out of 5 of his friends who'd been in practice for a year, 2 of them were changing professions. And for me, when you're dropping out of your profession, never mind the student loan debt, but if you're dropping out of your profession and you're only a year in, you haven't started scratching the surface.
No. Yeah.
Yeah.
So.
And so for me, that would be the thing. I would probably say, like, just learn this because it's going to help you as a professional.
Yeah. That's such a good point. Yeah. You as a professional and your patients.
Exactly. Yeah.
Okay. I think that's all we have time for today, unless there's anything you want to add for us, Belinda.
No, I know you're going to kind of summarize who's going to be coming on, but I'm very grateful that you had me on for the first time round. I'm excited. I'm going to be on the other side watching all of these as they unfold every month. So thank you for having me.
Yeah. I just want to thank you so much, not only for the work you've done with me and your patients, but for sharing the knowledge and perspective with us today. That's definitely given us a lot to think about. And with that, if there's one thing I think Belinda and I hope you heard today, it's that, and take with you, it's that your pain science isn't just for the patients who are struggling the most. It belongs in every interaction with every patient, because pain is more about just a tissue. And when we start to understand that, it changes everything. How we listen, how we treat, and how we actually show up. And that gives us more options and more ways to actually help. And at the end of the day, that's why all of this matters. So thank you for being here and for the work you are all doing. That's what helps us show up better for the people we're trying to help. And yes, now to continue building on what we talked about today, next month, I'll be joined by Jen Welter, a physical therapist and fellow in pain science. We will be diving into what it looks like to apply pain science education with kids and teens, navigating POTS, hypermobility, and the many challenges that come along with chronic conditions. So it's definitely a conversation you won't want to miss. Thanks again, and we'll see you next time.
Thank you.